None of the producers have any financial interest in any of the products or procedures mentioned or shown in this film. No copyright infringement is there in the music used in the video. TRIAD, an association of three: Microcornea, a posterior capsular rent, Aphakia, and Soemmering's ring. A triad that one comes across once in a while. To understand it, let us understand the story of a microcornea. Microcornea often presents with a cataract, sometimes in a child because of syndromic associations, and sometimes in adulthood with increasing nuclear sclerosis. Often, this is a hard brown cataract because of reluctance on the part of both patient and surgeon to operate a high-risk eye. Cataract surgery is difficult. The microcornea is associated with a microchamber and a microbag. Phacoemulsification can cause damage to all structures. Despite requiring a large incision relative to corneal size, it is therefore often better to do an extracapsular cataract extraction in order to avoid damage to the posterior capsule, iris, and endothelium. However, even with an intact posterior capsule, it is difficult to seat an IOL within the smaller than normal capsular bag. The optic fills up the bag and the haptics fold over, unable to open fully. The IOL power required is generally high, and it causes overcrowding of the capsular bag and the angle, increasing the risk for IOL tilt, uveitis, and glaucoma post-operatively. Implantation of a foldable IOL in a microcornea case is like a fetus in a womb and gets crumpled in the eyes. Thus, these patients are often left aphakic after lens aspiration or ECCE. In addition, cortical removal is often incomplete in this difficult eye, leading to a Soemmering's ring soon developing in the peripheral capsular fornix. And that results in our triad of problems: microcornea, posterior capsular rent with aphakia, Soemmering's ring. What does this lead to, and why is it a special situation? These patients need extra high plus spectacles and would benefit greatly with an IOL, but the Soemmering's ring can complicate surgery and its results. Why is that so? Surgery can be difficult, and it can cause an IOL to tilt, thus distorting already poor optics even more. Drop during surgery. The Soemmering's ring can dislodge and drop into the vitreous through the posterior capsular defect, causing vitritis and consequent problems. In addition, in a monocameral eye, it can also migrate to the anterior chamber and cause endothelial decompensation. What then is the answer for these patients? The advantage of the intrascleral haptic fixation, glued IOL or Yamane technique is that the optic is inside and the haptics are outside. The reason in this is the haptics are always outside, so we only need a 6 mm optic inside the eye. We published glued IOLs in microcornea eyes in the JCRS. A trocar anterior chamber maintainer is first fixed, which has the advantage of a valvular incision. This technique was also published in the JCRS. It is fixed about half to 1 mm from the limbus. A retinal trocar can be fixed, but the problem in microcornea is we do not know where the pars plana is, and in such cases one can get a choroidal hemorrhage or even a retinotomy. We fixed the trocar AC maintainer and created the scleral flaps, followed by sclerotomy under the scleral flaps, and we notice Soemmering's rings. We have published an intraocular lens scaffold in posterior capsule rupture in Ophthalmology Journal in 2013, and so we thought to try the same thing for Soemmering ring cases in which there is no posterior capsule. We published this in the JCRS in 2015. A glued IOL is then performed in such a way that the optic lies under the Soemmering's ring. The IOL haptics are trimmed and tucked into place. Iris hooks are now fixed so that we can see the Soemmering's ring clearly, and using the vitrectomy probe, the adhesions between the Soemmering's ring and the periphery are broken. Once these are broken, then the Soemmering's ring is brought to the center and emulsified very easily with a phaco probe. The IOL acts like a scaffold and prevents the Soemmering's ring from falling down. This is done in a 360-degree manner all around till the entire Soemmering's ring is removed. Once it is cleared, the iris hooks are removed. Finally, fibrin glue is applied and the case closed. This technique deepens the chamber, prevents angle crowding and angle closure glaucoma, as well as gives a well-centered, stable IOL without tilt. There are no loose fragments of the Soemmering's ring which can dislocate in the future. The surgical results are thus very gratifying, both anatomically and visually. What are the advantages that this technique offers us? First, there is no risk of IOL tilt anymore. Secondly, there is no longer crowding of the IOL within the eye. The haptics are brought out and the optic sits comfortably within the eye. The glued IOL allows the iris to fall back and prevents angle crowding. The intrascleral chariot tuck helps stable placement of the IOL. Thirdly, there is no risk of post-operative dislodgement of the Soemmering's ring fragments. Lastly, the glued IOL scaffold technique helps prevent intra-operative drop of fragments. So, what are the other options for such patients? Sulcus placement after haptic trimming. In this technique, inexact sizing in the form of unequal shortening or over-shortening can result in IOL decentration or even a mobile IOL. Customized IOLs with smaller optics and smaller overall diameter. Single-piece acrylic IOL cannot be implanted in the sulcus, and 3-piece customized IOLs have to be ordered. Customization can, however, be expensive and may not be universally available. Supracapsular glued IOL. In case of complete 360-degree Soemmering's ring, a supracapsular glued IOL technique may be done so that the optic sits over the anterior capsule and the haptics are brought out for intrascleral haptic fixation. Surgical manipulation needs to be gentle without disturbing the Soemmering's ring. But all the above options work well only with 360-degree Soemmering's ring within an intact anterior capsule so that the anterior surface is flat to allow fixation of the IOL without tilt. In eyes with broken anterior capsule at the time of original surgery, the proliferation may not have a uniform anterior surface, and this can result in IOL tilt if left behind. Thus, we see that this evil triad can be managed well with a glued IOL scaffold technique, resulting finally in a stable, well-centered, well-positioned IOL without tilt and without any crowding of the anterior segment of the eye.